So here's article number 1. So I want you to think. You've taken this patient, they're low, moderate risk. You're worried that they may be having coronary disease. So now we're going to do this test, this CT coronary angiogram, or actually or we'll do a triple study. We'll look for everything. We'll look for PE plus coronary artery disease plus aortic dissection. What do we find? In the first article, 34% of the patients were normal. Normal meaning there's no PE, there's no coronary disease, there's no dissection, and in most cases, if you're given that information, what do you do with the patient? Why would you admit them at that point or do anything further? You've got the answer to the question you're asking. A PE or a dissection was found in 20%. That's a little high for me. Pneumonia in about 35%. I'm waiting to see an article, and I'm sure there must be some out there. But have you noticed the number of patients where the chest x-ray is normal, and then you're working them up for belly pain or something like that, and you get a CAT scan, and then it shows an infiltrate in the lower lobes? It's really quite striking to me. Maybe that'll be our new test for pneumonia. If you have a cough, runny nose, sore throat, we'll get a CAT scan on you. We'll CAT scan your sinuses. We'll CAT scan, make sure you don't have retropharyngeal abscess. Coronary disease greater than 50% was found in 29%. Now, when they say that that the test is 81% sensitive, this is what they mean. Compared to me taking you to the angiogram suite and actually doing a coronary angiogram on you. And then I look at your lesions and I decide whether that lesion is more or less than 50%. And then you're going to do the CT coronary angiogram and see if it agrees in the same way. So that if I call it 55% and you call it 45%, that's a false negative. Why that's considered the measure, I have no idea. It's a completely irrational measure. And it doesn't, but it causes a lot of confusion about how good this test is. Other disease was found in article number 2. Again, this is low-risk patients that you're worried about coronary disease. Another diagnosis was found in 11% that was believed to explain their symptoms. Another 14% of patients had things found which were serious, but were not, they couldn't attribute the symptoms to that particular finding. Of these 201 patients, 10 were, these are low-risk patients now, 10 were found to have severe stenosis, 12 moderate stenosis, 46 mild stenosis, and 129 out of the 201 patients were found to have no coronary disease. Now remember, you're talking about low-risk patients, so you would expect to find 5, 10, 15% of patients to have something, and the rest to have either nothing or something else. So this is, now for those of you, if you see somebody, actually let me just tell you my practice and let's debate this. If I see somebody that has unexplained symptoms, of which coronary disease is in the differential, they get it, and it's new onset, they get admitted to the hospital. Because I have not had the capacity yet to work them up in the emergency department. How many of you have chest pain units here? Or can do extensive workups, including stress tests or that sort of thing? So a small handful. So the rest of us in the room are pretty much relegated to either admitting the patient or rolling the dice and saying, you know what, I feel like taking a few risks today with your life, so I'll send you home. So this is, I will tell you that my own personal experience with this reflects what this shows and has helped me tremendously in guiding patient care. I don't remember if I told you this case yesterday. A good friend of mine, first measured as having hypertension at the age of 20, is now 41, complaining of 6 to 8 months of chest tightness when she goes upstairs. It goes into her left arm. It hurts her a little bit when she moves her arms. She had a prolonged episode that lasted for about 2 hours the week before, and now it was the exertional symptoms were getting worse. So she had a falling spell. She came to the emergency department actually to have a wrist check, and I found all this other stuff going on with her. Her blood pressure was 180 over 110 in the emergency department. She had a little bit of early AV nicking in her fundi. Normal cardiogram, didn't show any LVH. And I called a good buddy of mine and asked, could you arrange, if everything's negative in the emergency department, could you arrange for a stress test on her today? And he said, well, if she's a friend of yours, I'm going to refuse. So why is that? He said, because if she weren't a friend of yours, I'd be happy to take her, do the nuclear stress test, and then do the cath and get all the money for the study. But why don't you just get a CT coronary angiogram on her and let me know what the results are. So I got a CT coronary angiogram on her, and her calcium score was 2. Now, a low calcium score is 100 to 200. So she had a very low calcium score, and she had completely clean coronaries. So now this is a woman that now is not going to get a nuclear stress test, and she's now not going to go for cath and angiogram because of that test. So now I think Rick mentioned this earlier. Can you, when you do a CT coronary angiogram, get a good look at the pulmonary arteries enough so that you can rule out a PE? And the answer is clearly no. If you want to look for the pulmonary circulation, you need to do a triple study. Who's not good for a CT coronary angiogram? Well, if you have stents in, right now that's not recommended. Although remember, about 5% of stents malfunction within the first 2 or 3 weeks after they're put in. And there is a peripheral literature over here that's evolving to look at the use of a CT coronary angiogram in that setting and whether or not whether it's useful or not. If you have arrhythmias that can't be controlled, the patient can't hold their breath for 15, 20 seconds, or they can't lie down. If you can't control their rate, if they have a high creatinine so you can't do contrast, or if they're allergic to contrast, you can't do it. And remember again, while they're doing the test, they like to give nitro to maximally dilate the arteries, so you have to check to see if they've been on any erectile dysfunction drugs. Also, if they are on drugs for pulmonary hypertension. They're the same drugs as the erectile dysfunction drugs, they're just under a different brand name. So anybody with pulmonary hypertension, make sure that they're not on the nitrous oxide or nitric oxide agents. And that's that for the contraindications. Technical limits, at least on our machine, you can't do it on somebody more than about 350 pounds. Although you can get somebody on the machine up to 550 pounds now with these new machines. So this is going to also cause an interesting debate about what the gold standard is. I don't know if you remember when troponins first came into being, that they were only 80% sensitive or so because they didn't match the CPKs, because the CPKs were the gold standard. And now we've just reversed it. We've made troponins the gold standard, so CPKs aren't as good. Right now, coronary angiogram is not as good as a CT-CA, so you scratch that and because it's not as good. But this may well turn things on their end. So just as a quick poll in the midst of this, one of the great risk of this is over-testing. So how do we avoid over-testing? The only way I know of to avoid over-testing is to not put somebody on a path to begin with. So this has been a big issue with pulmonary emboli. With pulmonary emboli, we used to have a certain notion of who that patient was, and then we go and test for them. And then the PIOPED study came out, the first PIOPED study, and threw a wrench in a lot of our thought process. For instance, it showed that 10% of patients had normal pulse oxes, 10% had normal heart rates, only 15% had diagnostic chest x-rays. So our previous entry criteria that you had to be hypoxic or you had to be tachycardic was now thrown out. Since it was thrown out, it necessarily expands the number of people that you're testing. So now when you look at the literature on testing for PEs, we have just exponentially increased the number of people that are getting CT angiograms of the chest to rule out a PE. I must say my own personal experience with this has been shocked many times to discover somebody has a PE that I really in the past might not have been suspicious. So it's difficult for me to reinforce less and less testing. One thing I have found very dangerous in our emergency department is the casual ordering of D-dimers on patients who are at no risk for anything, but when the D-dimer comes back a little bit abnormal, now somebody feels compelled to go chasing after these tests. So I think the way to avoid over-testing is to not test the no-risk patients. But here's where we get the rub. Our view of no risk is different than the admitting physician's view of no risk, at least in my experience at every institution I've worked in, is that the admitting service is, why are you admitting this person? They're looking at the patient 24 hours later, everything's been fine, so if everything's been fine, why did you have to admit them to begin with? This has always been a great mystery to me in hospitals. One of our case managers come down and they will bring me a case that's this thick, and they say, why do you admit this patient in the hospital? They didn't need to be in the hospital. I said, well, what's the story? Well, they've been in the hospital now for a month and a half, and we can't get rid of them. Therefore, you should have in 2 hours figured out how to get rid of them so that we wouldn't have to take the next 6 weeks to figure out how to get rid of them. So that's the sort of environment that we work in. So how many people work in places that are crowded? Or where you're holding patients, or where you would benefit from admitting 4 or 5 fewer patients a day. Well, that's this issue of over-testing. And what we do know at our place, I don't know if you've looked into your places, if we admit somebody and they're a low-risk patient, the inpatient service doesn't do anything with them. And when they follow up, most of those patients don't get anything. So one of the reasons we were interested in wrapping stuff into the emergency department is we thought actually they would get better care and they would actually get a diagnosis of what was going on. Because if you're truly suspicious, can anyone give me a pathway which does not involve radiation? If you actually think the question needs to be answered, does this person have coronary disease? How do you get at that answer? The lower the risk, okay, let's start with plain stress testing. It's the only mechanism you have available where there's no radiation. But the lower the risk, the higher the probability of a false positive. But also with low risk, the higher the probability, paradoxically, of a false negative. So for the population you're most concerned about, it's the worst test. So aside from that, what other options do we have available? You have nuclear stress test, you have coronary angiograms, and now this new thing, we have CT coronary angiograms. Those are pretty much your options for testing. I myself, when I was, this is about 15 years ago, driving to work, had severe epigastric pain, lasted for about 20 minutes. I was a little sweaty. It hurt a little bit to breathe. And I thought it was actually gallbag, so I went and did a quick echo, and the gallbladder was clean. So I did had one of my nurses do a cardiogram, and she did it. And unfortunately, one of the cardiologists was there and got a look at it before I did. So he said, what's going on with you? What's going on? Because I had some minor STT weight changes in my infralateral leads, you know, between friends, no big deal. So he said, well, we better do a stress test on you. So I did a stress test, had deep, about 5 to 7 millimeter ST depressions in my infralateral leads. So they took me for cath that day. And on cath, I had clean coronaries. It's a false positive stress test. So if you're in this circumstance, if this is you as the patient, I'll give you one option. Option A is I'm going to admit you, they're going to take you up to the cath lab, they're going to put this needle in your groin right here, it's going to go up to your heart, you're going to lay on the table, they're going to turn you this way and that, and they're going to squirt this stuff in you. And it's sort of interesting what it does. It gives you a lot of ventricular rhythms. That's sort of cool to experience. The thing that's really bizarre to experience is when they do this one injection in your aorta, there's a sense of fire that starts on the top of your head and it sweeps down your body, if you're a man, to your testicles and then exits out of the room. But it feels like you're passed through a slice of boiling water. It's the most unusual and uncomfortable sensation in the world. And then actually the best part of the cath is once you're done, they put you in a room and they give you these simple instructions. Don't move for 6 hours, which is the absolute worst part of the cath, is just don't move for 6 hours. No, you moved. No, don't move for 6 hours. Or you move one time, we'll make you stay another 6 hours. So that was my experience. Now I contrast that with, give me the other option. While I'm sitting in the ED bed, just order a contrast coronary arteriogram on me. Send me over there. It takes 2 minutes to do it. It takes about 45 minutes to read it. And they come back and they say, it's normal, go home. I didn't have to be sedated. I didn't have to, well, I wasn't sedated, but I was given Benadryl because I was getting itchy. And after a couple of doses of that Benadryl, I was a little goofy, so they wouldn't let me drive home. But this is so much easier that way. The cancer risk. Now they talk about radiation risk, that it's, the number here is 24 millisieverts, which is equal to 250 chest x-rays, which is like flying back and forth to Denver 200 almost every day of the year. These numbers are a changing target. I will give you our numbers for these. I just got from our radiologist. I emailed him last night and asked. For a simple CT angio to rule out PE, with our 64 slice, it's 5 to 8 millisieverts. For a CT coronary angiogram, it's 3 to 5 millisieverts. For a regular coronary angiogram, it's 7 to 8 millisieverts. And for a triple study, it's 7 to 13 millisieverts. So that's the radiation. So it's half the 24, but the least radiation that you can give to the patient. Oh, and also nuclear stress test is about 7 to 8 millisieverts. So the least radiation you can give to the patient is CT coronary angiogram. It's about half of the other options. However, the highest dose is if you want to do the triple study to rule out everything. That's going to double your dose to 7 to 13 millisieverts. So they talk about this stuff with the cancer risk. If you're a 20-year-old and you get this study, you have a 1 in 143 chance of getting cancer, whereas when you're 80 years old, it's 1 in 3,000 chance. The thing that strikes me as so odd about this is if the chance is really 1 out of 140 in a 20-year-old, and we've been doing CAT scans for almost 40 years, why don't we have concrete evidence now that this is true? I don't mean to disregard this, but it's just odd to me that we can't actually prove this. It's still speculative. I think that there are some imaginable ways that radiation exposure in a CT suite might be a little different than radiation exposure from a nuclear bomb, which is the arbiter for radiation exposure, because you don't inhale nuclear and radioactive stuff presumably when you're in the CT suite. Klein did a study. This is article number 6. And he looked at, well, if you get a CT, how many people come back and get repeat CTs? And he found, well, a lot of them do. And this is even worse. They're going to get even more radiation exposure. And that is the curse of CAT scans. The curse of CAT scans is that you actually make diagnoses. Once you've had the diagnosis of pulmonary embolus, every time you come back and you're short of breath, what are you guys going to order on the patient? Well, if you want to avoid radiation, you can start with Dopplers of the legs and see if you see clot. If you see clot, you're done because it's the same treatment. Otherwise, you got to go, or you can do an echo of the heart to see if they've got a saddle embolus. Otherwise, you got to repeat the CTs. Article number 7 says, hey, just remember there are other alternatives to doing CT angiogram for PEs. Don't forget the nuclear, the lung scan. And how many of you still doing lung scans? A portion. I think it will enjoy a comeback a little bit. One of the good news from all this stuff about radiation and harassing about radiation, the numbers I give you from our site, 3 to 5 millisieverts for doing a CT coronary angiogram. When this stuff started, it was about 15 to 20. But they have advanced the software, they've advanced the different programs so that they reduce, because that's been their focus now, is to try to reduce the amount of radiation exposure, and it has really dropped dramatically. So I want you to imagine you're going to work tomorrow. You see a whole bunch of chest pain patients. I'm somebody, I've got 3 stents. I got 1 stent put in 2 weeks ago, and now I come in with retrosternal chest pressure going up to my jaw with nonspecific STT wave dynamic changes. This is not a big mystery. We know exactly what to do with these patients. I'm somebody that's 45 years old, and I come in, and I've just had, the story is I get these vague aches in my chest. It lasts for like 10 to 15 minutes, usually with exertion, sometimes with stress. They've been going on for the last 2 or 3 weeks. They come and go, come and go, come and go. And exams normal, cardiograms normal. How many of you would send such a patient home? Anybody? So a couple would send them home. And what would you arrange for them to do? outpatient stress test. And if their outpatient stress test is positive, negative, you'd be done?
Oh, it was negative, maybe not, depending on whether their symptoms were returning. And they might get referred off to cardiology to consider angiogram if he's
So you would refer them, and it'd be really up to the doctor that receives them as to whether they do anything with your patient. But if they did, they may do a stress. If the stress is negative, they may stop. If the stress is positive, they may continue. The problem is, what if, and we see these patients all the time, is that the stress test was negative, but the symptoms continue and they come back to the emergency department. What do we do? Now, I want you to imagine that now you get a CT coronary angiogram on them in the emergency department, and it's negative. Now what do you do with the patient?
sent home back to his GP.
Yeah, just send them back to his GP. Say, congratulations, you're done, you don't have heart disease, go back home and enjoy yourself. Unless everybody's got syndrome X. But other than that, you're really done with that patient now. And you did it with the minimum amount of radiation and the minimal amount of time. So it's really a magical thing that happened then. Now let's suppose that there's this atypical patient, really funny patient, and you get a CT coronary angiogram, and it shows they have 95% stenosis of their left main. Send them home? Admit them? Okay, you've got the diagnosis. Now somebody will complain, oh, you just gave them contrast. We can't turn around and give them contrast again, except, well, really they can, but there's not necessarily a mad rush to do so either. But you've made your diagnosis again. Now you have the intermediate results where somebody's anywhere between 30 to 70%. This is where you need to sit down and decide with your cardiology group, how do you want to deal with these patients? They have real disease. It's not advanced enough that would cause stenotic type symptoms of stable angina or of exertional angina, but they do need aggressive medical management to prevent that from continuing. So you've helped that patient as well. You may also find dissection or pneumonia or whatever else. You're not going to find PE with this. Now I want to vary this case of the guy that for the last 2 weeks has had these funny symptoms that come and go. I'm instead going to have the exact same symptoms this guy did, pressure in my chest, and it went up into my neck a little bit, and I was a little sweaty and a little short of breath, and it came on 3 hours ago, and it just lasted for 2 hours, and it's feeling a lot better now. But I don't have a framework for this. I can't, when you ask the patient, no, I've never had this before, I don't get this going upstairs, I don't get this when I walk out in the cold weather, yes, I have 3 risk factors for coronary disease. What's the best test to get on this guy? Option A is you can just admit him as a rule at ACS. What are your other options? What would you be concerned about? This is where you get stuck. The only reason you wouldn't think about PE is he just has no risk factors for PE, but 5% of PEs have no risk factors. But you've got this guy that had sudden shortness of breath, and it lasted for a couple hours. You're worried about it, and it's fair to put on your list in your differential. Could be coronary disease, could be PE, whatever else. This is your guy that'd be a perfect setup for a triple study. Because if the answer to one thing is negative, you got to worry about the answer to the other thing. So pick one study, you're left looking at the other study. So this, you would expose the person to probably around 10, 12 millisieverts, which is a little more than CT coronary angiogram, but it would give you 2 answers at once. Does he have a PE? Does he have coronary disease? I actually had a very similar case of this a week ago. 70-year-old lady comes in. She's got a history of heart disease, no history of PE, and had exactly this. Since last night, she's just suddenly short of breath. And the shortness of breath has persisted through the night. She doesn't look like she's in failure. Chest x-ray doesn't look like she's in failure. We got a triple study on her, and she had a PE for the first time ever. So we could have just gone with CT, the regular chest CT, but the opportunity was there to nail it. Oh, I forgot. The other reason we did the triple study is she had a history of a thoracic aneurysm. We knew that, so we wanted to take a look at that and see if it had progressed. Before I stroke you out with any more stuff about CT coronary angiogram, I hope you pay close attention to this topic. It's going to be transformative in your practice. More and more pressure is on you not to admit these patients, but to work them up in the emergency department. And you have to work in the following paradox. Don't admit them, work them up, but we're not going to give you any way of working them up. We're not going to let you do stress tests or anything else. So this gets you around that and allows you to get the answer. Neil, you want to come on in and